welcome everyone to Grand Rounds. My name is Dr. Chip Taylor, and I'm a family physician here in Roseburg, Oregon. I have the privilege of being the inaugural director of our Roseburg Family Medicine residency. I'm a retired Navy captain and had lots of opportunities to practice integrating public health into my practice throughout my time in the military and beyond. I originally set this up and was going to talk pretty academically about things that you need to know to set up a response. And then Dr. Longenecker and I were talking, and we really thought we ought to get into the why. To facilitate conversation, we ought to get into the why. And so that got me thinking about a book I read years ago, about 30 years ago, by a guy by the name of Robert Fulghum. Published a book titled Everything I Needed to Know I Learned in Kindergarten. Anybody read that book? So it talks about things like sharing, don't hit people, play fair, lots of basic things. And I recalled that I had the opportunity to have at least 2 kindergarten experiences as a young physician. And so some of the things that I learned in my medical kindergarten, and there are lots of them, this is just the one that's most germane to what we're talking about, is that as a rural clinician, we're called to navigate almost seamlessly between the patient in front of us, the population that's entrusted to us, and the community in which that care occurs. Does that make sense? So whether we're talking about community medicine and outreach, or we're talking about, changing statistics on a metric, or, changing individual patients' behaviors, those are all things that we do. And I think that this principle really flows in. So let me tell you about some of the formative experiences that I had, and then we'll move forward to how that plays into my practice today. And then hopefully that will generate questions and thoughts, and hopefully the slides will be enjoyable to see. So in 1987, at the tender age of 26, after completing my internship in family medicine, I was sent to kindergarten, where I was the only doctor on board this U.S. Navy ship. This is the USS Camden. It's a fast combat support ship. It's a big supply ship. Carries enough food, fuel, and ammunition to keep a carrier battle group going for a week. And it no longer exists. This has been replaced. We're now probably shaving with it. It was 797 feet long, 107 feet wide at the widest point, and there were 40 feet of the ship underneath the waterline. It was a big ship. 650 sailors, and I got to live, eat, work with them, go on liberty with them. This was my community. These were my patients. Now, I say I was the only doctor on the ship, but I had several enlisted corpsmen who helped me in my work. And each of those folks had some special skill. So for instance, I had a radiology technician to shoot x-rays, and a pharmacist, and I had a laboratory technician. But the person that I learned the most from was a rather unassuming middle-aged gentleman who was my preventive health tech, who was responsible for making sure that the food we ate was safe, that the water we drank was safe, that we were adhering to all of the standards for the workplace, and for doing contact tracing should we have an outbreak of anything or with STDs on the ship. I learned a lot of things on the ship that applied to this principle. I learned that even though I was the doctor, many of the patients had their own doc, the corpsman that they most affiliated with. And so if you were African American, you saw my African American corpsman. If you were, one of the chiefs and the senior enlisted, you saw my chief corpsman. If you were, in this particular group, you saw the preventive medicine tech, and so on and so forth. And they were able to do magnificent work. Early on in my time on the ship, we had a helicopter crash. And what I learned from that experience was that there was not enough of me to go around. And my job was to train and equip the corpsmen to do their work. So I tell you all these things because this great laboratory of the ship is not unlike a rural community. It's just about the right size that you can see the individuals and the populations and the community. And so while I was on the ship for 2 years, almost a full year of which was just like this picture, underway out of sight of land, I had 3 projects that were community-wide that I feel quite proud about. The first one involved obesity. We would get these young sailors who would come to our ship fit and thin from boot camp, and immediately they would go down and work on the mess decks for 3 months, and they would balloon up. And so we were able to work with a dietitian at the local hospital to come up with a low-calorie option on the mess hall. So when they went down the line, they could choose the Camden Warrior diet, which was signified by a logo, to try and reduce their weight. And so that was the first thing. And the second thing was, I had the privilege of making 2 cruises to the Western Pacific and Indian Ocean with a ship full of men at the beginning of the AIDS epidemic. I saw every STD known to mankind after our first port call, and I was convinced that there was something that I needed to do in my second tour. So I'm very proud of the fact that our STD rate on the ship was 50% of the rest of the battle group on the second cruise. And I won't bore you with the details of the multi-pronged approach that we used, but it was effective, and it involved primary prevention. And I feel confident that we saved some sailors' lives and trauma to families and loved ones back in the state through that intervention. And then the final intervention that we did also involved lessons that I learned on the first cruise, where I joined about 2 months before we returned home and found that 12 out of 650 sailors had been returned from sea because of suicidal ideation. It's a pretty stressful time. The Stark had just gotten blown up, and we were a huge target. If our ship got hit by a missile, we created a 10-mile radius hole in the ocean where we used to exist, and so it was stressful. So we implemented a stress management program to help people coping with just the separation and so forth, and we didn't have anywhere near as many returns. So the nice thing about having an experience early on is that it forms a culture within yourself to think about future interventions. Because much of what we do, whether you're in family medicine or surgery or whatever, is about trying to improve the health of our population. So very much what public health does. So now I returned from sea and went to Jacksonville, Florida for residency. And then I raised my hand again and volunteered to go overseas. And I got sent to a beautiful repeat kindergarten, which was an isolated command that we had in a little island off the coast of Sardinia. The island was only 20 square miles total. It's at a mile off the northern coast of Sardinia. Sardinia is 200 miles off the coast of Italy. It wasn't quite the end of the earth, but from my balcony way up on top of the hill over here, see under the kindergarten, there was a big hill. I could see the end of the earth, okay? And what I learned from that experience was that we were at the end of the supply line. And I found this out because we had our first child when we were over there. And if you ever meet my son, Alex, please don't embarrass him, because he wore girl diapers more often than he wore boy diapers.
Yeah, apparently
that was what
the other lady called
in the supply line. Did someone have a question or a comment? Okay. So while that was a little bit embarrassing for us when we had to change our son in public and he had pink diapers on, what really became apparent to us was that my partner and I were seeing lots of babies with diarrhea. That was the presenting complaint in the clinic. And they were normal, healthy kids who were bottle fed, and the poops were changing because the formula was changing. from 1 week to another based on availability in the commissary. So we had a problem. We were seeing it with individuals, and we were seeing it in a certain population. So our moms, we didn't deliver babies on the island. We did prenatal care and we did postpartum care. And then at about 37 weeks, you got sent over to Naples, Italy to have your baby. So there was this gap between the time that you had your child, you came back, and a 2-week visit would occur. And in that gap, we were losing people to breastfeeding. And we identified that if we could increase the breastfeeding rate across the community, we would have less work to do in the clinic, seeing these babies with changing poops. And so we thought, and we scratched our heads, and we talked to people, and we found that there was a lactation consultant in the community who we could rope into helping us out. And then we really lucked on to finding a woman who had trained as a British nurse and was familiar with doing home visits. So in Britain at that time, every woman who had a baby had a home visit every day for 2 weeks after the birth of their child by a midwife. And so this was just part of the British tradition, which we were able to import. Not 12 days, but we got the women of the chapel to put together a layette, so it was part of their community outreach, and we could have the nurse go and visit these families, check on them, try and connect them if they were having difficulty breastfeeding. And we increased the breastfeeding rate from, an abysmal, maybe 15% at 2 months up to close to 80%. Now, it was a very small N. We only had about 25 to 30 pregnant women at any given time. It was easy for us to do an intervention like this because it was a self-contained community. And then the other byproducts of this were that we were able to see where they lived and identify risks for postpartum depression and risk factors for abuse and isolation. This was a great experience, and I have used these experiences throughout my career. Now, if we fast forward, we still see patients, one patient at a time as a general rule, whether we're doing it virtually or in the clinic. We have technology which allows us to communicate with patients and to view their data easier and in ways that we couldn't do when it was a paper chart, where we can take the chart note and lay it on a side and put it together with all the other people that have diabetes or hypertension. And now we have a profile, a panel, and go from there. So this is our particular clinic, and this is during the pandemic. And the intervention that I want to talk about is getting people in rural America to put masks on, right? So a challenge. How do you do it gracefully? How do you convince them to wear them, in the clinic and in public? Well, so our community is fiercely independent, and there were lots of folks who, as a political statement, didn't want to wear a mask. And so how do you do this? The way that I approached it over time, as I sort of developed my spiel, was I would enter the room wearing my mask along with my MA scribe. I would be very consciously washing my hands, and I would thank the patient for wearing a mask, even if they weren't, and remind them that it would protect them if they were, because I see a lot of sick people and I don't want to infect them. Then I would segue to remind them that COVID is a serious illness. And in our community, what seemed to do the trick was to use the statistic that more people have died in the last year of COVID than died in combat in World War I, World War II, and the Vietnam conflict. And then, because these are my patients, I was able to read their response to that. And if they were still looking like they weren't very interested in vaccination and so forth, I would tell them the story of the last soldier that died in World War I on the US side. It was 1 minute to the armistice. And I would say, I say this today, I don't want to have one of my patients be the last person who dies of COVID in this epidemic in our community. I really want what's best for you. Let's talk about the vaccine. So let's talk about that as a principle, because you could use that same idea whether you're talking about obesity or cholesterol medicines or diabetes and so forth. You're planting a seed with one individual. You're using the skills that you've practiced and honed in motivational interviewing and so forth to think about how that's going to magnify across the population. Smoking cessation. Data suggests that there's a 1% chance that your patient will quit smoking just because you mentioned it, because their doctor recommended they quit. It goes up if you do other things. So the patient in front of you is really key, and it ties into the community response. So can anybody guess which picture in here is Dr. Taylor? I'll let you off the hook. I'm in the lower left corner. That's back when I was a young Navy doctor delivering babies. And this is the best delivery I ever did. In this particular picture exemplifies the idea of a community. These women were both part of, their husbands were on an aircraft squadron that was deployed to Sicily. And there were about 6 of them that would come in whenever one of them was in labor. And they were all dualists for each other. And the woman on the left there, at the time that I was delivering the baby onto the mother's abdomen, got the old landline phone, because that's where we were at back then, dialed her husband, the woman who was giving birth's husband, over in Sicily, and the baby was able to cry its first cry into the phone, and he was able to participate. Now, why do I tell you this? Because having been deployed, I understand what it's like to be deployed. That was a very special population. And so we were able to make that birth special to them. Today, my population looks much more like the population in the upper left-hand corner. As you get older, your population ages. I take care of more people who I have the privilege of helping them die well than giving birth at these days. And unfortunately, I've had several who died of COVID in this epidemic. And so I feel very strongly about the need to try and protect our populations. So my point in all this isn't just to tell some cute stories. My point is that in all of our practices, whether you're an internist or a family doc or an ENT, you have populations. And if you're in rural practice, your population is more diverse than you might think, because we do all comers, right? If you're in an urban area and you're in the middle of a Hmong community, chances are you're going to have a lot of those folks in your practice, or if you're in a Hispanic community. But here we have everybody. And as an FQHC, we really do have everybody. So, so the ability to think about your population is really important. And it's probably more diverse than you think at first. Now let me segue over to the second to last slide. So all of this care occurs within a community, and this is my community. This is my church. This is my hospital. This is my main street. Right down here, oh, that's the Hanson here. Kind of down the street there is the kitchen store that my wife likes to go to every time we're downtown to make sure she buys something and keep it in business. It's a great place to live. You go 20 miles to the east and you're in the Cascade Mountain Range. You go over the hill outside of town and you're in wine country. Like most rural communities, our community is poorer, sicker, and older than our urban counterparts. And we're blessed because our community had the foresight to become a Blue Zones demonstration project. So that's what you see down here in the lower right-hand corner, some of the principles of a community-wide effort to improve the health of the community. In the middle is one of my residents participating in part of a CSA food box project that we did to provide fresh fruits and vegetables to people suffering food insecurity. And then up above is some of our faculty, one of whom is on the call here, and some of our residents at a mass vaccination clinic. And I know that many of you have been involved in mass vaccination clinics. So if you are able to think about the patient in front of you, the population in which that patient exists, and the community, and think about our overall goal of improving the health of rural America, then public health and what we do every day fit together hand in glove. And so this is the Venn diagram of my ideal practice. I take care of individuals one by one. I take care of groups of patients. They're mostly older. They're usually married. They're oftentimes poorer than their rural counterparts. And all of this occurs in a rural community that I call home. And that's important because for many of our colleagues in urban areas, they're not living in the community they serve, but we do. So it's very important for us to be part of the community.